All right, you can see the first slide. So my compliments to the group that actually came back after lunch on time. You're an extraordinary group, and we're thinking of what could our workaround be to get the others to be as good as you. But listen, in order to keep us on time, I really do want to start this, and people will be coming in. So this is the next chapter in our edited book metaphor. And what we wanted to do here is to look at instances where workarounds are the norm in clinical care. And the organization of this panel, I'll show you who the speakers are by clicking this, right? Am I doing that right? No, probably not. There it is. So we're going to begin with Ellen Deutsch, and she's a simulation expert, or she has told me a simulationist. Okay, and that will frame some of our conversation. And then we're going to go to Rich, because his expertise is in oncology, and so the patient population is mostly people with chronic illness. And then to Steve, where as an ED physician, he sees a plethora of people with acute conditions. Okay, so that's our structure here, and we'll look at workflow and workarounds. So we're just going to get right into it, all right?
Okay, and our section is when workarounds are the norm in clinical care. And I have no disclosures. We have a really interesting and unique system in Pennsylvania where reporting incidents and serious events is mandatory by the ECRI Act, Medical Care Availability, and I practiced it so many times, the ECRI Act. And the reporting system is confidential and non-discoverable at the point where the reports leave the facility and come to the Patient Safety Authority. And we do not collect the name of the patient or the name of the provider, but we collect information about the event. It's a combination of granular and free text reporting. The reporting through the PACERS, Patient Safety Reporting System, PACERS has been in place since 2004. We have actually approximately 3 million reports, event reports in our database. The incidents and serious events come to the Patient Safety Authority. The serious events also go to the Department of Health. We are separate organizations with separate responsibilities. So we have a rich database, and one of the things that's unique, it's one of the broadest and oldest state reporting systems in the country. The reporting is based on harm rather than error. So if a patient is harmed, including death, or if a patient could be harmed, then that should generate a report, an event report. And I think it's very important because there are things that cause harm that aren't necessarily caused by errors. And the other thing that's unique about the system is that it's not just events which caused harm, but events which could have caused harm, and even unsafe conditions which could cause harm, not necessarily to a specific patient, but as a process. So from that reporting system, we present, the authority's role is educational, and we analyze the reports that we receive, and then we put out either information in the aggregate, or we put out, we do describe some of the narratives, but we always do them in a de-identified manner. So I have some stories here. These are, I say stories, but they're actually true events that were reported through the patient safety reporting system, but they've all been de-identified. The details have been modified, so you can't tell where they came from. But I want to give you some examples of workarounds that we've seen in the reports. And as the previous panel sort of implied, people who submit these don't always label them workarounds, but as you read the content, you understand that they're workarounds. So in this first one, the nurse was unable to scan the barcode before administering a medication because the barcode was incomplete. So she contacted the pharmacy, and they told her to type in the patient's name and medical record number and to document manually that she had administered the medication. And this workaround benefited the patient because the patient got the medication they should have gotten, but the process didn't address the underlying problem, so it was a first-order workaround. Another true example, the barcode reading was invalid when the nurse scanned it, and the nurse contacted the pharmacy, who determined that the medication was non-formulary. So the pharmacy instructed the nurse to override the error message and to administer the medication. But in addition, the pharmacy suggested that the nurse report the event to the facility's incident and serious event reporting system. So in this case, the patient benefited, and the documentation that the nurse provided could be used to support investigation of the problem and mitigation to prevent this from being a problem with future patients. And in this last example, the patient brought a high-risk medication into a patient who is in respiratory isolation. And once again, he or she was unable to scan the barcode before administering the medication because the barcode was incomplete. So the nurse gave the medication and then returned to where the high-risk medications were stored in order to scan an undamaged one for the purpose of documenting. At that point, the scanner indicated that this was not the correct medication for this patient. So in this case, the workaround bypassed a safety mechanism, creating a patient safety hazard. So these were all essentially the same actions with very different results. And as we look at workarounds, I think we have to think about some of them really are, as Ronnie said, some of them are trash, some of them are treasures, but all of them are opportunities for us to learn because they are all evidence of a system that doesn't support the functions that are expected or needed in that particular circumstance. So I do agree that rather than thinking of workarounds as mistakes or deviance, that we ought to think of workarounds as learning opportunities. So the other thing I'd like to speak about is this notion of work, because a workaround, which I personally don't think has such a negative connotation. I think it's sometimes a very creative solution. But Terry and I are both devotees of the resilience engineering community. So we both talk about work as done. And what we really want to understand and what we want to optimize for patient care is work as it actually occurs. But it's very hard sometimes to understand that. So we often use work as imagined, and work as imagined is a theoretical construct. Maybe it's a focus group, maybe it's an interview, maybe it's a planning session. Work as imagined is a valid view of work, it's just not a complete view of work. Similarly, there is work as claimed. So some patient care events generate malpractice claims. These do give a perspective of work, and often institutions pay attention to them because there can be significant financial implications of the claims or consequences of the claims, but they are a lagging indicator, and it's a subset of events. So again, it is a way to look at how work has been done. It has limitations and it has attributes. There's also work as documented. We spoke about that, or the previous panel spoke about that. In this image, the documenter is using paper, but this could easily be an electronic health record also. We know that, we heard that sometimes people save the documentation until they go home at night. So you have to wonder about the accuracy and completeness of the documentation based on the skill of the documenter, the time interval between the event that's being documented and the documentation, and possibly also the ease of documentation. So, and this work as documented is often the source of information for trigger tools, it's the source for administrative databases, for billing. It's important information. It's not always complete, and it may, and there may be some inaccuracies in it also. There's work as abstracted. There was some excitement about that in the previous panel. Hugely powerful, a way to look at information that we gather, data that we gather from patient care interactions and to analyze it in a nonlinear fashion. Potentially very powerful. must be based on accurate premises, because when you have big data, you can get reliable results, but you have to also make sure that those results are accurate. We have work as observed. One of these people observing might be leadership, and that could change how the person doing the surgery is performing. There could be Hawthorne effect, because if you try to observe work, it inevitably changes it. But it's also possible that one of the observers is an expert, maybe a human factors expert, or an anthropologist or a sociologist, or even a content expert who may see things about work that the participant actually doesn't recognize. And then finally, there's work as simulated. And I think work as simulated is a very powerful way to look at work. It approaches real work. It's not the same, it's not identical, but it can come pretty close, especially if you have real people, real teams, using real equipment, participating in simulations in actual patient care settings. And there are a couple of ways that this can set up a learning situation. One is that after the simulation, it's always integral to the simulation that there's a debriefing. And in the debriefing, the participants, we classically think, or we often think of simulation as either being used to have individuals improve their skills or to have teams improve their skills. But we can also use simulation to look outward and look at the environment that surrounds us and see if the equipment is in the right place, or if the protocol actually works in the real patient care setting. There's a lot of simulation used in preparation for potential patients with Ebola, and moving the process into real physical spaces brought additional learning. So there is the learning that can occur from the articulation of what people did. We can support what people did well. We can look at, we can certainly talk about what could be improved, but it's also important to reinforce what people did well. And again, Terry touched on this a little bit. This is the principle behind safety too, that there's actually a lot that can be learned from looking at what goes well and reinforcing good activities and effective treatment. The other thing that we can learn in simulation is there's an affective lesson. If the simulation debriefing is conducted in a skillful, constructive, positive manner, then that models the behavior that is constructive and that supports learning. So those are my thoughts about getting to workarounds. I think broadening the content beyond electronic health records and thinking about a whole lot of other workarounds that occur. People use estimated weights when they dose medication. People use surrogates for healthcare providers use surrogates for consent when there's a circumstance that prevents them from getting consent from the person undergoing a procedure. Healthcare providers substitute medications when there are shortages. They use different equipment. They substitute equipment when there are shortages. So it's not just about working around electronic health records. It's a much broader scope than that. People hoard. There's a workaround. If you know that there's a shortage of suture removal kits, you might want to put a couple in your pocket so you're ready for the next patient. And workarounds are sometimes endorsed by the organizations. I think one of the most classic workarounds that we commonly talk about is boarding. Boarding's a workaround. You want to get the patient from the ED to whatever inpatient unit is appropriate, but there's not room yet, you board them. That's a workaround. So I think workarounds are much more pervasive, and I think they are often, as Terry said, positive things. These are ways people cope to get it done for this patient. And the important thing is to step back and then understand why the workaround was necessary and what could be learned from it.
Okay. Thank you.